So I'll make no secret of it. I think the COVID vaccine is a miracle. Now, when it first came out, I was like, mRNA vaccines, really? Why do we? That's kind of weird and new. Why are we doing this? And then I thought, well, I better go read all the data I can find on this. And I read all the data on it, and I came away and said, oh my gosh, that's someone deserves a Nobel Prize. I'll be honest. So, um, but I understand why people have vaccines. If you're anything like me, my first inclination when someone says you have to do this is well, I was gonna do it, but now that you told me I have to do it, no, I'm not gonna. I don't want to do it. And I feel like there's been so much politicization of this that it really leaves a bad taste in people's mouth. And there's this big push by one side of one political party one way, and the other one resists it, and it unfortunately this has become very politicized. And so these are some of the most common questions, concerns that I come across, and some of them that Shearson identified with me too, that I'd like to talk about um, uh, from a scientific perspective. So when it comes, we all kind of grew up in this society and the way news is and the way media is, where it's like a legal type of thing where we do persuasive discussion. Like, doesn't matter if the guy's guilty or not. It matters how good his lawyer is. It doesn't matter in the media what's right or wrong. It's all a persuasive discussion. And a big part of going from a regular person to a healthcare scientist, and every doctor and nurse has to have a pretty good handle on science, is kind of abandoning persuasion for data. And I feel like that's the way I really have approached all of this. These people say this, these people say this. My question is, where is the data? Is there good enough data to make a decision on some points, or is there insufficient data? When you look at evidence in medicine, that's the way it goes. So there's either good enough data or there's not good enough data. If there's not good enough data, we fall down to expert opinion. Expert opinion, because the experts actually understand what happens at the cellular level and can predict a little bit better what the outcome is going to be for an unknown entity. And then we fall down to anecdotes, which are really the weakest and poorest. The vast majority of what I see in the media is anecdotes, just stories that may or may not be related, silly stuff. It's just unfortunately not very helpful. In the early part of COVID, a lot of what we were told was conjecture from experts, some of which was disproven, not necessarily because they're wrong or foolish, but just because there wasn't good data. And now we do have a lot of good data. So this is Idaho cases of COVID. So you see, last report was September 13th, 1,450 cases. We were really high in the winter, like we always are. Respiratory viruses thrive in the winter. It came back down. People thought we'd beat it. I think those of us who've been doing this for more than a decade knew that it would come back in the winter, like the flu and RSV and all of those things too. And unfortunately, we're getting our winter pretty early this year. You can see, compared to a year ago, cases, and this isn't just in Idaho, but in Utah, are significantly higher than they were a year ago, which gives concern. And I think is what is causing some institutions to make these policies where they mandate vaccines. I'll be clear, I don't really feel comfortable with a lot of mandates, but I also recognize that I'm not in charge, and my choice is to evaluate the data and decide, regardless of what anyone else has told me, is this good or bad for me? So that's what I'd like to do with you guys today. All right, so first question that was posed, one of the biggest questions I've heard from young people, from the nurses that I work with, from young patients and other things, is this vaccine safe for pregnant women and women who would like to become pregnant in the future? And you'll see it, everything I've said, I've included at least one good source at the bottom that you can reference. So early in the pandemic, there were two guys in Europe. So Mike Yeadon and Wolfgang Vodard, who's a British and English scientist. The British guy was touted as a leader of the former vice president of Pfizer. That's what all the articles said. Former Pfizer vice president, comes out against vaccine and fertility. you look into it, he was the vice president of the asthma division of a small division in Kent, England. He wasn't the vice president of Pfizer. He was, a researcher in a small subset of Pfizer, and he was the vice president of his little department. He's a pharmacologist. He's specialized in pharmacy, and he worked with Pfizer to develop respiratory asthma type treatments. He was not an immunologist. And then the other guy, Wolfgang Bodard, was a German physician. Nobody real special. He's basically family doctor in Germany. And I don't want to just blow off their concerns, but the concern they raised was cross-reactivity. So if you get a vaccine, you make these antibodies to this spike protein that we've created through mRNA. Are those antibodies going to cross-react to proteins involved in pregnancy? And the specific one they identified with concern, because it's a reactive protein, is called syncytin-1. We'll talk a little more about that. But anyway, they raised this concern and they wrote a letter about it to the European Union governing board, and unfortunately, it just caught on like wildfire and really heavily promoted by people who obviously don't want the heavy thumb of oppression telling them what to do with their lives as something to raise as a concern. The thing I feel like I find is, you look at all this media stuff. I feel like media companies, they make money if you listen. They make money if you click. And so they just love to talk about the most extreme and concerning things. Spent some time looking over media ratings for the last couple of years, and most of the media people, both right wing and left wing, have experienced incredible ratings during the COVID thing and made a lot of money. And gosh, I really think it's unfortunate that some of the fringe ones, like, they're willing to say whatever they need to make money and promote stories like this that are controversial to get. Anyway, so let's start with the ACOG clinical guideline. So ACOG is the American College of Obstetrics and Gynecology. ACOG is strongly in favor of the vaccine for pregnant women and for women who would like to become pregnant. They did this. If you look at this article, it's a really long article that summarizes a lot of data. Everything that was available at the time. There are a whole bunch of studies in rats and rabbits before the Pfizer and Moderna vaccines were released. They did a bunch of studies with rats and rabbits that showed no effect on fertility. They quote those studies as animal studies to support it. There was no negative, there was no downside, there was no evidence of miscarriages from the vaccine, there was no evidence of difficulty with pregnancy with the vaccine, and so those are the studies that are in there that are pretty good, well done studies. But then there's a whole bunch of more opinion and what they're saying and stuff like that. Let's dig a little deeper though. So before we talk about the vaccine complications, I want to talk about the COVID complications. So I have a lot of people who tell me, well, I've got lupus, so I don't want to get the vaccine because of what it could do to my lupus. And my response is, if you think the vaccine's going to be hard on your lupus, you should see what COVID does. Because from what I see, it's way worse. So I have personally either seen or been in the department when we've seen young pregnant women in their 20s with severe complications from COVID. I've seen a young woman in her 20s who's pregnant end up on ECMO, that's heart-lung bypass. I've seen one end up with a tracheostomy because she couldn't get off the vent. I know another one that was in our ICU that was on the vent for about a month, and they're trying to decide whether to do a tracheostomy. I saw one who, 23, healthy, clotted off her entire leg with blood clots as part of this. And we see a lot of unfortunate complications. So first study here on the left, this is a large study where they looked at what happens in animals when COVID infects animals. There are a whole lot of ACE2. So you guys know ACE inhibitors, like lisinopril, all those things are designed to work on blood pressure. Those ACE receptors are what COVID likes to bind to, the ACE2 receptors. ACE2 receptors are overrepresented in the uterus and the ovaries. So there's good studies in animal studies where they, kill them and dissect them and things like that, that shows that COVID really likes the maternal fetal interface. It really tends to collect in the placenta. It really has a lot of activity there binding to those ACE2 receptors. Even when you don't find the virus in there, you do find high levels of inflammation and immune activation. It's been proven on a cellular level. Another one, COVID infection in males shows a decreased sperm count. That's been proven now that you'll significantly drop the sperm count in males after COVID infection. Interestingly, I'm not going to just do scare tactics. Both of these go away. So like if you had COVID, that doesn't mean you're going to have fertility problems. It does increase the miscarriage rate, but like 6 months later, you're back to normal. There are no long-term effects. I just threw this in there to be silly because ivermectin we've known for years decreases sperm count in men. That's been well studied for more than 20 years. Ivermectin, I've both prescribed and taken ivermectin because I've done third world medicine in Honduras and stuff. And it's anyway, it doesn't work. So here's a good article that looks specifically at spontaneous abortion. That's the medical callous word for what we would say call miscarriage. We call it a spontaneous abortion. So this study looked at specifically at that. This mirrors what I've seen. You know, as an ER doctor, a lot of women come to the ER for miscarriages. I have seen many miscarriages. We see many of them associated with a current COVID infection. And so this shows this increased risk. So if you are newly pregnant, especially first trimester, and get COVID, your chances of having a miscarriage increase. Now, they don't dramatically increase, but they increase enough that you can see a trend in literature and you can see a trend in the emergency department. And this is a really good article, really well done, lengthy article if you want to read it. Like I said, we've seen it in multiple pregnant women in later cases too, but especially in the first trimester, there is an increase in miscarriage. The COVID vaccine, on the other hand, has not been shown to do that. So I've got two good studies here. So this one, in the first one, comes from a large fertility center where they've been looking at COVID vaccine effects on fertility since January of this year. Several hundred patients through this. They basically test everyone to see if they've had COVID antibodies, see if they've had the vaccine, test for their antibody levels, ask about if they've had prior infection. What they found, and they're doing in vitro fertilization, implantation of frozen embryos, so they can keep really good track of it. Exactly when it happened, exactly when the implantation happens, exactly, what the hormones are doing. They found no implantation rate difference between women who've had COVID, women who've been vaccinated, and women who've had neither. They have found to date no changes whatsoever. They feel strongly with the amount of data they have that they can conclude already that there is no difference, that COVID vaccine has no effect on fertility. Number two, so there's a Yale immunologist that I quote here. She published her research in the New York Times. I think she was trying to reach a broader audience, and I know that it's not a popular newspaper with conservatives, but it's a really well-written article from this researcher. She's a Yale immunologist. So she took that idea from these Eden and Wodarg, these guys that were concerned about sensation 1, and she actually tested it. So she took antibodies from people who had both had COVID and people who had the COVID vaccine. And in the lab, she artificially cross-reacted them with over 5,000 human body proteins, including sensation 1. That's one that the consumer raised about. What she found is there was no cross-reactivity. It had no effect. These antibodies that come in and they bind in a specific way and to the spike protein, and they did not have any binding affinity towards sensation 1. So she basically took their idea and she just buried it. So here, and if you want to go search, this is a good research article, and the New York Times article is very scientifically written, not opinion written. I really think she put it there just because to reach a broader audience. But these two really bury the idea that sensation 1 could be involved. Really bury the idea that there's any kind of effect on fertility. just not being seen. I put a couple of YouTube videos on here in case, in case you want to share this. These are both from directors of fertility clinics. One at Mount Sinai, a huge clinic in back east, and the other one actually the clinic director for the clinic that did that study. And both of them say, in our data that we're watching closely, we see no effect whatsoever on fertility with the COVID vaccine. On the other hand, they have seen lots of effects on not long-term fertility, but early pregnancy miscarriage when you have a COVID infection. Let's dig a little bit more into that. So like I said, I've seen multiple pregnant women with complications during COVID. And that's the hard thing is you see them and they're like, well, I didn't want to get the vaccine because I was pregnant. I thought, my heart is not exposed to anything. And unfortunately, they didn't get a COVID infection. So I've seen early pregnancy, mid-pregnancy, late pregnancy. Probably 2 days ago, I had a 4-week-old baby where the mother said, I didn't want to get vaccinated during my pregnancy. And then the baby was born and she got COVID and the baby got COVID. And I had to admit this little tiny 4-week-old baby to the hospital with respiratory distress. And it's devastating, And she's saying, I don't want to expose my baby to the vaccine, but the risk of COVID, the Delta variant is so contagious. It's unfortunate. You kind of are choosing your risk, the vaccine or COVID. You have a high risk of getting COVID. So here's a nice big study looking at 64,000 pregnant women and what happened to them with COVID. So we know now that pregnant women are more likely to develop severe illness and disease than non-pregnant women. Almost every 20-something that I've admitted to the hospital female has been pregnant. They're more likely to require ventilation. They're more likely to require ECMO. They're more likely to die from COVID than women usually are during pregnancy. They're more likely to have a premature birth, causing problems with the baby. And then the last question, we have no idea if the treatments are safe. We do monoclonal antibodies, we do remdesivir, we do things like that. We have no idea if that's safe for the baby. I mean, these are medications that work on a cellular level. We have no idea how safe they are. So we're really, there's a lot of experimental stuff to save these lives and don't know what effect that has. Here's a systematic review of 192 studies looking at 64,000 pregnant women. So 17.4% of women who had COVID developed pneumonia where you could see it on the chest x-ray. 17% had to get oxygen with cannula. And these are not 50, 70-year-old women. These are women who were fertile and pregnant. 13% developed ARDS. 11% had severe disease. I mean, that means 9 out of 10 are not going to. But you compare that 11% of severe disease against almost no measurable change with the vaccine in studies. That's fairly convincing. 3.3% were admitted to the ICU. That's a very high ICU admission rate for an illness that's affecting young people. 1.6% required invasive ventilation, meaning either BiPAP or, you're talking about healthy 20 and 30-year-old women, 2% of them encountering this virus are ending up on a ventilator. Really challenging. 0.11% required ECMO. ECMO is basically like last ditch. Let's see if we can save your life with a Hail Mary before you die. And I personally am familiar with one pregnant woman for ECMO. And then 8% died. People say that it's an 8% mortality rate. That's that's less than 1 in 100. It is, but this is 1 in 100 of healthy young women, healthy enough to get pregnant. That's the point I tend to continue bringing up. If you're scared of the vaccine, you should see what COVID does to people now. And being in the midst of it, I take ICU transfers from all across Utah, all the way from from Cedar City to Vernal to Price, Moab, and stuff like that. And we take them in, and then some weeks end up to Intermountain Medical Center in Salt Lake if we. I see stuff coming in from all over. Oh, and every day I have this conversation. Even Monday I was in the ER, and this lady, her 4-year-old with asthma was fairly sick with COVID, and the mom herself had been feeling pretty lousy. She said, "I'm going to be honest. I've been out there posting all this anti-COVID, anti-vax stuff. I feel like the biggest kid in the world." I've had that conversation almost every day for a year now. But this is, so let's move on to the safety and efficacy. So I found the best data I could on what happens with the 3 big vaccines. So, well, I guess to back up and summarize, I think all the data that I can find suggests that the COVID vaccine has no effect on fertility and pregnancy. All the data that I can find suggests that COVID itself has a brief effect on fertility and a severe effect on both pregnancy loss and a severe effect on maternal health during pregnancy. Pretty solid data to support both of those. We conclude that the risk of getting the COVID shot is far outweighed by the risk of contracting COVID during pregnancy. Anyway, so here's the 3 main vaccines we use in the United States: the Pfizer, BioNTech, Moderna, and then the Johnson & Johnson. And this is the data that was released by the FDA when it was approved. This is what we've seen in the studies. So you can see with Pfizer, we do see side effects: local injection reactions, systemic infection, fever, chills, fatigue. Part of that is the mRNA, because you're not just putting proteins in, you're putting the mRNA in, so your body can't just neutralize it. This is my little boy just got back from kindergarten, so for the interruption. But so the mRNA keeps pumping out these spike proteins even after your body's tried to neutralize it, and that's why one reason we get such an immune reaction. Your body's like, man, this keeps coming. I thought we had an immunity to this, but because that's very effective in building an immunity. So these are the things you see. Are there side effects? Yes, there are. Myocarditis and pericarditis happened in 16 per million people. That's a really low rate. That was an approved finding by the FDA. They said, yeah, that's what we see in the data. The Moderna vaccine, very similar, 16 per million myocarditis, local injection reactions, fevers, chills, fatigue, myalgias. Most of these are short-lived, less than 12 to 24 hours. Have I seen some people in the ER after vaccine? Yes, I've seen a few. Like, I'm talking 5. I haven't seen a single one since May. Almost all of them were the Moderna. Almost all of them were the type that they were like, I feel so terrible. I can't go on. And I'd say, did you take ibuprofen? No. Did you take Tylenol? No. Did you drink Gatorade? No. I've not seen personally a single severe reaction to any of these vaccines since they've been out. I don't know of any of my partners in the ER who've seen either. Johnson & Johnson, I don't like the Johnson & Johnson. I don't think anybody should get it. I don't think they should since the beginning. You look at the efficacy at 60%. That's generous, I think. It's waning and it's worse than that. It's a recombinant adenovirus, and I'm just not impressed by it. It has more side effects: thrombocytopenia, where your platelets drop, increased clotting factors. Has at least one case reported Guillain-Barré syndrome, probably a couple more cases. It's not as effective. It has more risk going for it. Pfizer and Moderna are far superior. I got to go back here. How do you click back on this? There we go. I went all the way back. So I'd like to reiterate. When COVID first came out, I was just like, oh yeah, here we go. I've been doing this 13 years. I've been through the swine flu and the bird flu and the West Nile and the dry drowning and all those things. I was like, the media's new favorite darling. They're going to get clicks. They're going to scare all of us. I'm going to have people coming to the ER saying, I think my kid has dry drowning. I think my kid has COVID. Yeah, it's going to blow over. I was really skeptical. And then I started seeing COVID, and I've never seen anything like it. And the chest x-rays that would have once blown me away have become normal. I'm very data-driven. I'm skeptical. I don't like what the media tells me. I don't like people that do it. I'm very data-driven, however, and I'm only using data to support my conclusions here. So the Delta variant. We thought we would get this virus under control. The Alpha variant had an R naught, meaning the amount of infectivity. So if I get Delta on average, if I get the Alpha COVID variant, on average, I would affect 2 to 3 people. The Delta variant, its mutations are so much more infective that on average person with the Delta variant infects 8 to 9 people. So it's significantly more infectious. So we used to think that if we could get a herd immunity, either through acquired immunity or vaccination status, that we would need about 70% before COVID no longer became endemic problem. Unfortunately, the Delta variant is so much more effective. It's become the dominant variant across the world, and we're probably going to need more like 90% immunity before we start having these surges. The Pfizer and Moderna vaccines, and especially the Johnson & Johnson, seem to be less effective against the Delta, but it remains high. So it's at least 90% at 6 months, like probably against the regular variants. It's probably about 80% effective against the Delta, unfortunately. However, well, when you look at, sorry, I can't figure out how to click back when I'm doing the screen sharing, but when you look at severe cases in hospitalization, it's still almost 100% effective at keeping people out of the ICU. It's 99% effective, even with the Delta. Pfizer is the best studied of all the vaccines. They really got their act together. They really studied everything well. So a lot of this data is only good on Pfizer. It's not good on other stuff. Here's the effectiveness that we see for the duration against things. So 96% effective at preventing infection. Now you hear the stuff on the news. It doesn't affect your risk of getting it. It just affects your risk of getting ill. That's not true. It does decrease your chances of getting it. And then if you get it, you have less viral application. You have shorter viral application. You're less contagious, less likely to get sick. So it's still very effective at keeping people from even getting symptoms or having a positive test. That wanes over time. See, about 90% at 2 to 4 months, about 84% at 4 to 6 months. And this number down here is why people are starting to talk about boosters, and that's getting a lot of attention. It certainly isn't a mainstream idea that is being promoted in the medical community, but we consider, we'll see how things go. This is a question I get all the time, and I think it's a great question. How protective prior infection? People said to me all the time, I've had COVID before. I'm not worried about getting it again. I don't need the vaccine because I've had COVID before. That's exactly the thought process I had for the 46-year-old guy I saw last week who has COVID for the second time, and I put in the ICU. So we're unfortunately now seeing multiple people who have a second documented COVID case. So I saw a guy, 46-year-old guy. He does have diabetes, but not super unhealthy. He had a documented COVID case in December. He didn't get the vaccine. He came back last week. I personally saw him. He was short of breath, had significant changes in his lungs. His oxygen rate was low. I put him on nasal cannula, was not effective. Face mask, then non-rebreather. I had a non-rebreather at 15 liters and I could not get his saturation over 89 or 90. I ended up having to put him on BiPAP and put him in the ICU. Now that's an anecdote. Remember I told you anecdotes are weak. So, but just illustrating that it does happen. I unfortunately have seen with my own eyes a patient who thought they were protected and is now in the ICU on mechanical ventilation at age 46. So, but prior infection is effective. In fact, prior infection is just about as effective as the Moderna vaccine is. Prior infection is slightly more effective than the Pfizer vaccine. Prior infection is much more effective than the Johnson & Johnson vaccine, which again, I don't like at all. So prior infection is effective, it is. And we do a disservice by not talking about that. However, there are studies looking at this as well, because people with prior infection are getting infected again. It's a small group, it's not a huge group, but it is happening enough that I've seen several cases personally here where I can go in the computer and document a positive test last year and a positive test this year, and they're sick. So why are we promoting vaccination of those who've been infected? This is why. When you look, so this comes from a big study back east where it's a COVID monitoring thing based out of the University of Kentucky. They basically look at infectious rates. So some people, after they get the infection, they get vaccinated. No, what they found, those with a prior infection who haven't been vaccinated are 2.3 times more likely to get reinfected than those who have been vaccinated. So the vaccine boosts the immune system. Why? that's what this cool pictures here. So these are spike proteins. Now you know that spike proteins look like gummy bears. I'm kidding, but I like that picture. So you see, when you have a protein like this, so your body makes the virus makes this protein. The mRNA makes your body make this protein, so it floats around your system, and your body comes in and makes an antibody that binds to its site. What we've found in studies is that with the infection, there tend to be fewer antibodies, more focused antibodies. With the COVID vaccines, again, you keep exposing your body to it. That's one reason there's such side effects, because you really pump a lot of spike protein out of your cells, and your body just gets super angry and is like, gosh, I'm so sick of this. And so it makes all these different antibodies that bind in different places. There's really good evidence in a cellular laboratory level that the antibodies that come from the vaccines bind to more sites and bind more effectively against variants. What you see with the variants is you get transposition of a couple amino acids. It slightly changes the shape of the protein, and then the key no longer fits anymore. So from your infection, the key was made for this specific protein. If you've got an alpha and a lambda and a beta variant, the key doesn't fit anymore. You're more likely to have more keys that fit in more places when you do the vaccine. Now, again, prior infection is effective. It is effective, but prior infection plus a dose of a vaccine makes you more protected. I fall into that category where I had the prior infection and decided to get vaccinated anyway because of the data that I saw. My wife and 2 teenagers, I also felt very comfortable doing that with them, even though we all had the infection at the same time, including this little guy leaning up against me. He had a fever for 1 day and then he was better. Amazing how light this is on kids and how bad this is on us. All right. Another question I come across, people are like, I don't want to get COVID when I'm going to get the flu shot too. I don't want to combine these vaccines. Is that a good idea? So we've been doing this for years in kids. In fact, it's been a big complaint for prior anti-vaxxers that were anti-vaxxers before it was cool. But we do lots of combined vaccines in kids. And here are 3 good studies you can reference. You can read them if you want to. They're all long and ugly and dated filled, but basically showing that if you combine vaccines, you can do COVID and flu the same day. And all these studies demonstrate that you don't tend to get worse symptoms. Your symptoms aren't going to be any worse than the COVID was itself. And you get good efficacy. Your body is able to simultaneously fight and create immunity against 2 different viruses at the same time without any detriment to you or to your rate of immunity. I really, the 3 good studies that study this in depthly and really, I think, put that to rest. All right. Here's a good question that people ask me. This is the biggest thing I wondered when the vaccines came out. I said, why mRNA? We've trialed a lot of mRNA vaccines. They've been tried with cancer. They've been studied. They've been around for 3 decades and they've been studied. They've been tried on a lot of humans just out of curiosity. There's never been anything that was big enough that was worth launching it, so it didn't really catch on. And there was never anything where it proved effective enough. It was like we were figuring this out. We were almost there, and then we came up with this pandemic that was the perfect time to go prime time. But why mRNA? I was like, when you look at vaccines, most of them are a few different kinds. One, a live attenuated virus. So that's the polio virus we use most commonly. Live attenuated, meaning it's really weak. It gets in, it gives you some symptoms. Your body attacks it. You're immune. It's great because you can actually spread it a little bit to other people. It induces community immunity. It was a great polio vaccine. The other thing we do is we take a little chunk of the virus and put it inside you, and your body reacts to it and makes immunity. Now you're immune. Fantastic. That one can't infect you. It's very safe. The other one, we just kill the virus completely, put the whole thing in you, your body gets immune to it and deals with it. Why did we do mRNA for COVID? This is the reason. So we have 4 other coronaviruses that are very similar to COVID, but not as virulent or bad, that circulate through the population. We see them all the time. It's cold. Unfortunately, we can get all these viruses multiple times through our lives. In fact, there are multiple studies of coronavirus outbreaks in skilled nursing facilities that have up to like a 8% mortality rate. Even though these folks at 80 have had coronaviruses a long time, our body does not build lifelong immunity to it. Most people don't know that in the last several decades, more than 60 vaccines have been developed against coronavirus. 60 vaccines, a whole bunch of killed virus, a whole bunch of live virus, a whole bunch of chunk of protein type of viruses, and every single one of them has failed. And, people outside of science don't understand that. They're like, I don't want to be a lab rat. There's only one reason they went for the lab rat, and it's because they've tried to make a coronavirus vaccine 60 times the regular way, more than 60, and it just has not worked. And so when COVID came out, people were like, let's make a vaccine, and all the scientists who work on vaccines say, oh no, this is a corona. We have failed 60 times. What can we possibly do to stop this one? And then the mRNA folks said, hey, I have an idea. So mRNA is great because, you've taken enough cellular biology, I'm sure, to realize that that's the body's communication. So proteins go in, they take a copy of your DNA, they send this little mRNA transcription to the ribosomes. The ribosomes print it all out into a nice protein. So basically what we did is with the mRNA vaccines is we send this little piece of our mRNA into the cell, kind of alter the DNA. It has nothing to do with the DNA. And it goes to basically your body's protein printers. Your body has these 3D printers that are called ribosomes, and it makes these proteins, and the cells spit them out into the bloodstream, and your body can go crazy on it. The advantage of that, with a lot of the protein vaccines tried previously, the body neutralizes the protein so quickly that it doesn't make an effective vaccine response. In this way, your body keeps pumping these out. It's just like having an allergy or something. If you're allergic to peanuts, every time you eat them, it can get worse and worse and worse. Your body's like, I am so sick of this peanut protein, I'm just going to destroy it next time it comes in. You need anaphylaxis. That's what's happening. Your body's neutralizing it, it's taking care of it, and that muscle that you injected into is like, well, here's some more, and here's some more, and here's some more. And so your body gets super angry, makes a really diverse immunoglobulin response, just attacks it and goes crazy. And that's why we get more varied types of immunoglobulins against spike protein with the vaccine than we do for natural immunity. I think really, I think these people deserve a Nobel Prize. I don't know what that's doing. All right, young people. So another question I see all the time, young people come in and they're like, I don't need the vaccine. This is really mild for me. Okay, first, I agree, it's very mild. Unless you're one of the 12,000 people under age 30 who've died from COVID. Many of them have prior problems. I see that blown up. Well, these are people with prior health concerns. Yeah, but so if you have type 1 diabetes, it's okay if you just die and just write you off. I don't feel okay about that. I can personally tell you, I've hospitalized young people in their 20s and 30s who do not have any comorbidities, nothing. They were perfectly healthy, and now they have COVID severe enough to come into the hospital. We do not admit people willy-nilly. You only come into the hospital for one reason, and that is your oxygen will not stay above 88 without supplementation, meaning your lungs are in bad shape. Like, even if I wanted to, if I was like, you know what, you feel so lousy, I'll just throw you a bone and admit you. There's no way my hospital system would allow that. We're on such a bed shortage. So that takes me to my next number. It's 62,000 Americans under age 50. I wanted to parse this down more. I just couldn't find any data. 62,000 people under age 50, 49 and down, hospitalized for COVID. Huge number of people who've been hospitalized. Do a lot of them have other medical problems? Yes, but a lot of them don't. I have a 33-year-old guy I saw a couple of weeks ago who I had to put in the ICU because he has no health problems. He was totally fine, and then he's in the ICU on mechanical ventilation. Luckily, did not have to be intubated. After 7 days, he was able to come off the nasal cannula and go okay. But I have a 21-year-old I had to admit about 2 weeks ago. I mentioned that 46-year-old. He did have some comorbidities, but that other ones didn't. So this is a problem for young people, not nearly as much as for older folks. So we see it every day. My very last patient on my evening shift last night was a 22-year-old who was having trouble breathing. The most mild touch of exercise-induced asthma. Still played a bunch of high school sports. Took an albuterol inhaler like 3 times in his life during a football game, and now he's really out of breath. This is a bigger thing, and I put the link up here if you want to look at it. So this is a study looking at people ages 16 to 30, not just that. I looked at all age groups, but 16 to 30 who were 6 months out from COVID. 52% of them still had symptoms. 52% of people ages 16 to 30 had not felt like they were 100% 6 months after getting COVID. And I have another slide where we'll dig into that a little more. This is COVID admissions to the hospital per 100,000 by age group. So you can see at the bottom here, the yellow 0 to 17 years. It's really mild for kids. I don't understand why it affects kids so little. Most of the horrible viruses we've dealt with through the centuries have worked. It's really kind of great. It's almost like nature's like, I'm going to get all you old, people out of the way for this generation. I don't know. Morbid way of looking at it. But this is the hospitalization we're seeing nationally. So you see the old folks really got hospitalized a lot. The old folks, they remember polio and stuff. The old folks did not hesitate to get the vaccine, and they've drastically decreased their numbers. If you look at younger people than that, look at the 30 to 39, the dark green one there. We actually have more hospitalized from that in that age group now than we ever did in the winter at what we thought was the peak of COVID, because they don't think they need the vaccine. Look at this. All ages, we're approaching our highs there. Look at the 30 to 39. So the 40 to 49 was a dark green. The 30 to 39 is this dotted dark green. Currently have more hospitalized than we ever have. And the same with the 18 to 29 group. We currently have more hospitalized in the US than we ever have. These are the groups that think that it's not going to happen to them. And unfortunately it does. Every day. I should have probably had these slides inverted, but this is that study for the people where it shows that 52% of people ages 16 to 30 still had symptoms at 6 months. So the most common ones are disturbed taste and smell, just never come back normal. Fatigue, memory problems, that's harder to justify. Headache, 10% of people ages 16 to 30 who had COVID still having worsening headaches 6 months out. Breathing problems, 13%. I have extremely mild exercise-induced asthma. I played a bunch of sports. I never thought about it in my teens and 20s after having just a little bit when I was a kid. 2 days before I got COVID, I ran 3 miles and worked out in the gym for an hour. And I felt great. I have not been able to get back up to running 3 miles 8 months later. My lungs are slumped. I unfortunately fall into this group up here where 59% still have symptoms. I'm one of the 1 in 5, apparently. Still, I'm hopeful that'll get better, but we'll see. Kirsten never told me how much time I had, but I'm getting close to the end of my thoughts anyway. VAERS. I wanted to bring up VAERS because I hate VAERS. Because everybody brings up, well, VAERS shows this, VAERS shows that. VAERS. Anyone can report to VAERS. Anyone. I put the link here. If you want to click on this and make a VAERS report today, you can. They don't ask if you're a doctor. They don't ask if you're a nurse. They don't ask anything. So if you have a neighbor who got the vaccine and 2 months later they got in a car crash and died, and you feel like putting that in as a possible vaccine side effect because you wonder if it affected their brain and their thinking, do that. Your aunt can do that. Your cousin who's a florist can do that. VAERS is not vetted. It's not questioned. It's not analyzed until later. Every report on there is completely subjective. It is really like the garbage dumpster of medical data. Is it useful? Yes, because we can go in there and start looking and say, okay, we're getting reports of this. Let's focus on this in the actual data where we can study and have information about it and see what we're finding. It is not useful for drawing conclusions, not in any way. It's not useful. All right. This is the hardest part of this, I think. Vaccine requirements. We had a discussion with our big ER group actually yesterday about this, about whether we should have a vaccine requirement, and I'm not a big fan of that. I think a lot of the hesitancy with vaccines is actually the way we've treated people. To come in and say, you're all dumb, do what I say. That's the best way to get people to not do what you want them to do, right? It just doesn't work. It's human nature. It doesn't work with my teenagers, it doesn't work with my 5-year-old. I remember thinking that when I was a teenager. I was sitting on the couch when the garbage was full, and I was like, I should take that garbage out. And my mom came in and said, hey, will you take the garbage out? And I was like, darn it, no, I can't do it. And my mom told me to do it. And we all have that inside of us, right? I don't like that. I don't like being mandated. That being said, hospital administrators are not known for understanding human psychology and treating their employees really well. Their answer to every crisis is a pizza party and more requirements and restrictions. You're not going to be able to have a career in healthcare without facing vaccine requirements. So these are the ones I've been required to get. My first healthcare job, hepatitis B, I could not start till I my hepatitis B vaccines. MMR, when I was in medical school, I'd had 2 MMRs already, but I was not allowed to start residency until I could prove I was immune to measles, mumps, and rubella. I had to get my blood drawn. I sent it in. I was 0.01 below the acceptable rate. So, I was like so close. My antibody titers, I had to get another MMR or they would not let me start residency. Influenza, almost every hospital system I've worked at requires an influenza vaccine. Some of them have been like, you either have to get influenza or you have to wear a mask all winter. Others, like the University of Utah, they said, show us your influenza vaccine requirement by November 1st or you're fired. You're suspended. There was no leeway, nothing. Get influenza vaccine or you're suspended November 1st, the end. And then TB testing, after that every year. COVID testing COVID has not been mandated yet. I strongly suspect that it will be. And again, I don't like this, but unfortunately, it's a fact of life. If you're going to work in healthcare, they're going to make you do this. We do it in schools. To register my kindergartner, I had to show his vaccines. To register my 7th grader, I had to show her vaccines. They've been requirements for a long time. Do I like it? No. It makes me want to rebel. It's my nature. I don't like being told what to do. Just ask my wife. But luckily, as a scientist and a physician, I can go review the data, look at it and say, you know what? This is a good idea. Even though I don't want to do it because of you, I'm going to do it for me because I have reviewed the data and concluded that for me, my children, my family, I strongly believe this is the best thing to do for me. And I strongly recommend it to my friends and family and community members because to me, the data is great and very strongly supports. So quick conclusions, COVID is by far more dangerous than any vaccine. 100 to 1, 1,000 to 1. COVID is far more dangerous for every condition, for every age group. And you're going to get it. mRNA vaccines are necessary because other ones failed, more than 60, and they're safe and effective. Herd immunity is pretty effective. It comes at a huge cost of hospitalizations, long-term symptoms, and death and illness. Acquired immunity plus a vaccine is about as protected as you can possibly get. And then Moderna, I would recommend for anyone who's never had the illness or the vaccine, I'd recommend Moderna. It seems to be the most efficacious. Had the infection, I'd recommend Pfizer because it's not going to be as miserable as Moderna. Anyway, that's the end for me. Thanks for listening.
Hey, Dr. J, like I say, you're no smirka. So he's like a doctor I use in my simulations, and he's not great. So I have always really appreciated you, that you've always been very data driven and that you're a clear educator. So when I was thinking, when we were trying to think of someone to come and talk to us, you were a very clear fit. So thank you so very much for doing that. I really appreciate it. I know there were some questions out there. One of the questions was, do we know what it is about coronaviruses that makes it so it's so hard to deal with the more traditional types of vaccines?
Mostly the simplicity. they're just the protein. The protein on the spike protein only has 384 amino acids, and it's just not that complex. So there are only so many binding sites. It's like influenza. Influenza has the H antigen and the N antigen, and they're actually more simple than corona is even. So that's why it's been so hard to get good vaccines against the flu that are lasting. So it's just the simplicity of it. So you put it in there, there are only a couple binding sites. The body doesn't really make good antibodies, and then you get it again.
Okay.
So it's too simple.
Another question is, so am I correct in my memory about the flu vaccine that says that actually the flu vaccine can be given now at the same time as the COVID vaccine?
Yeah, I don't see any problem with that based on what I see in the data and what I know about immunology.
Okay, I do say, and one of my, somebody asked about waiting 90 days, but I think the 90 days is just if you have like the Regeneron or something. Do you know anything about that?
90 days between COVID and the flu?
No, sorry, 90 days between getting COVID and getting the COVID vaccine. Sorry, that was my mistake.
I think that's a good idea.
So
I think that waiting 90 days, because your immunity has been here and now it's dropping down to here and getting, your body's relaxing. That better, rather than hitting your body when it's right here and it's got all the immunity up there, it's better to wait till it relaxes, and then it'll be like, what the heck? I just cleaned up this place, and make more immunity and more varied antibodies. So it's better to wait, in my opinion.
So now I know for some of our students, because I'm pretty sure the CDC website says you can get it. I think we looked at it, Jodine, was it 14 days after basically when you're out of isolation again, you could get the COVID vaccine unless you have Regeneron, and then it's the 90 days.
Yeah, I mean, if you've had something like Regeneron, you should wait longer, but you could get it in 14 days. I think that's the most miserable time to get it. Like if you hate yourself and want to feel lousy again, then get it at 14 days.
Right, which I suspect is like most people's experience when they've done that.
Exactly. I waited 90 days. I was not about to like rekindle my symptoms.
So another question someone had is, should they be concerned if they had like no reaction at all after the vaccine? They felt great. They didn't even like they felt fabulous. Should they be concerned that maybe it didn't produce an immune response?
No, they're actually, some people's bodies just, even though your body's making immunity and immunoglobulins, some people's like bodies, as you go down the histamine pathways and the complement pathways, get more angry and febrile and chilled, and some don't. So it doesn't actually represent your immunity. It only represents how aggressive the rest of your body fought it. So it's not a bad sign. So
another question is, I know like in certain countries, say Canada, I just happen to know, that they will let you take like one dose of like Pfizer and the next dose of Moderna. Is there any data to back that up? I know that's not approved in the United States.
I haven't looked at anything on that, so I can't tell you data, as we say here in the United States, but I'm just kidding. Tris and I have a long Canada joke history.
Yes.
I think that would actually be a really good idea, but I don't think anybody's going to do it. So that's what I've thought. I did Pfizer, and if I end up getting a booster, I only got my last one in the end of April, so I'm not even 6 months out. But if I got a booster, I'd probably try to get the Moderna just to broaden my immunity. I think it's not a bad idea at all. But
it seems like it would give you kind of two different profiles of the virus, almost.
Yeah, it seems like a good idea to me.
Something else, another question is, like, do you anticipate, or do we anticipate that this is going to have to be a yearly shot like the flu shot is?
So that's one of those things where I'd say, I don't know. There's not enough data. I tried to look that up. There's not enough data yet. I hope not. There are a bunch of vaccines that we do 3 times. The 2, 4, 6 months vaccines for babies are identical. I hope that this is a 3 and you're out, but unless it mutates a lot more right now, there's still pretty good immunity against the variants. Unless we get another variant, I doubt it. I would vote that we probably won't have to. Maybe it'll be like pertussis, where we have to get one every 5 years. I think that's more likely, but again, this is now you're getting to expert opinion, maybe non-expert because I'm not an immunologist, but I think that's less likely.
And then there is another question about basically the third doses, both as why are they recommending a third dose for immunocompromised people? And then also what have you seen about the research about the third dose just for everybody that they're talking about?
There's not any good research in the immunity of what happens. All the talk about the third dose is based on the fact that we're seeing at 6 to 8 months in some countries, not in all, the immunity drops closer to 80%. So they're saying if this immunity is dropping, maybe we should give boosters to immunocompromised people. The science is definitely not settled on that. It's definitely not recommended for healthy people yet. Now I kind of feel like if you've been vaccinated and then you get COVID, that's your booster. It's going to be mild, great, So it's almost, but it's just an idea based on the fact that we do see some weakening of the immunity, which we do with every illness, as your body, remodels your immunity, dials down the resources, says we don't need to have a full, Army and Navy stacked up against us anymore. Let's draw it down to reserves. So it's not surprising, but it's too early, I think, to answer that question. I'm not going to get a booster yet. I've had COVID and the vaccine, so.
Okay.